My name is Justin Beaver, and today we're going to be presenting Confronting Healthcare Cost Pressures, a patented framework for employers and health plans by IntegerHealth. With me, I've got Scott Roloff, our president, and we're going to go over data-driven analytics for employers and health plans to address rising medical cost ratios and absence costs in 2025. The agenda today, we're going to start with market trends and challenges, really unpacking what's driving rising costs in the market today. Then we'll go over our data-driven solutions and analytics. We'll go through some case studies that are proof points into what we've done with our analytics, and then spend a little time walking through our platform and what it can do for you. Finally, we're going to touch on actionable analytics and what those outcomes really drive, and then we'll spend some time getting in touch and answering questions. During the presentation, if you have any questions at all, feel free to drop them in the chat and we'll save those for the end. If at any point you have an issue with hearing, just drop that in the chat too, and we'll try to address any technical issues. If there are any technical issues or you can't hear us now, please let me know. Otherwise, we're going to get started. All right, so when we think about what's driving medical costs and rising costs for employers and health plans in the marketplace, it really comes down to four primary drivers. The first one is rising medical expenses related to increased instances of elective care. The second one is escalating specialty drug use, that magical GLP-1 that we see in the marketplace, fragmented delivery of care, and quality metrics and regulations. We're going to take a deep dive into each one of these on how it impacts healthcare today, and then talk about what we can do with patented analytics in order to drive better outcomes and lower costs for both employers and health plans on the call. First, rising costs. For those of you that haven't been keeping track of it, medical costs have been outpacing inflation for the last 3 years and more, in fact. It's rising at an estimated 7.5% per year for employers and individuals since 2021. It's this wonderful study by PricewaterhouseCoopers that goes over and basically forecasts the trend for what the costs are going to be and the anticipated costs for employers and health plans. The truth is, though, that payers and employers should expect this to be the paradigm. I don't know if anybody saw the recent inflation report, but inflation isn't going down. In fact, it's finding an uptick since rates have been coming down. Those are also going to walk hand in hand with costs related to medical costs. And these medical costs are going to increase pressure on your MLRs and drive premiums up unless we find a way to tackle MLRs at a patient and a diagnosis level. It's also tied to rising medication costs and utilizations. Really since 2021, the introduction of GLP-1s on a national scale for both weight loss and diabetes management have driven costs significantly. Employer Health noticed that from 2021 to 2023, that cost has gone up from $8.99 per member per month for employers, all the way up to $23.16 per member per month for employers. In fact, GLP-1s have been in the news a lot. In the last 2 days, we've seen reports both from Becker Healthcare and from Politico on just how GLP-1s are impacting both employers and health plans. For instance, states like Colorado are feeling the squeeze on the budget from GLP-1s now being 1 in 10 prescribed to both federal employees as well as the average American in the United States. They're looking at whether or not they should be continuing to cover this drug or strategies to reduce the costs. And I think the New Mexico Health Committee said it best, which is that the value of GLP-1s is a long-term value, right? You're not going to see the true benefit and cost savings from a medical expense cost for 3 to 5 years. But in many cases, we don't know if individuals are going to be on the plan, that health plan, for 5 years. So how do you realize those savings? We're going to go over how we use driven analytics to look at individual diagnoses and unpack exactly how you can drill into diabetes, drill into obesity, and figure out which physicians or which locations are driving those costs. And that way you can navigate your patients from high GLP-1 cost positions and locations to low ones. The pressure is also on for health plans. There was a recent report both for Blue Cross Blue Shield of Massachusetts that reported a $121 million loss in Q4, and they specifically pinpointed GLP-1s as the cause. And they're not alone. Other plans across the United States are seeing those costs rise because utilization of these drugs are rising. And while they do provide a true medical benefit, health plans are having a really hard time determining what the payback is simply because of that long-term value payback. So we need to be able to unpack that and look at treatment plans just as much as the prescription itself to determine how we can really address the rising GLP-1 costs instead of simply passing it on in premiums to our members or reducing coverage or eliminating coverage altogether. And pharmacy isn't the only thing to blame. When we look at fragmented care delivery in the United States, if we really unpack where our members are receiving care, we look at site of care as one of those primary indicators, or at least drivers in costs. And site of care costs have escalated drastically since 2021. Blue Health Intelligence put out an incredible report that I think kind of flew under the radar that showed, based on 121 million claims members, or claims from 2021 to 2023, that site of care costs at outpatient hospital facilities increased 27% over individual hospital costs, or sorry, individual instances of care at offices or ambulatory surgical centers. And this isn't related to just our high price surgeries or inpatient. This is all outpatient. The common procedures that your average beneficiary or your average member are getting, they've seen a 27% increase in those costs compared to physician offices, while physician offices have actually stayed steady at only 2%. So site of care really has a massive impact on what costs happen within your own membership. And when we're trying to unpack and think about it as both health individuals that design health plans, or people who manage risk, we have to take site of care into account. Now, there's been a lot of plans that have worked on site of care and even have site of care review policies. United Healthcare, Aetna, Cigna, everybody's jumping on board. But the truth is that these happen after the fact, right? They're always a look back. There's no way for us to forecast which location should be eliminated from the network based on those reviews. And they're really just, claim by claim. So when we think about when we want to navigate people away from high cost centers, we really need to drill down into the specific data related to those claims. And when you put it all into aggregate, it's a staggering number, right? Outpatient hospital procedures administer less than 35% of common outpatient procedures like imaging or standard, outpatient procedures where you end up going home, like diagnostic tests. But they accounted for $67 billion in cost in 2022, 2.5 times that of physician office expenditures. So when you're thinking about how you design your network or how we reduce costs, when we look at a market driver like this that says that site of care has a major impact, primarily because of the facility fees attached to these outpatient hospital facilities, we need to build a strong strategy on how to create a better network or how to navigate our members more effectively to move them away from these high cost centers. And then finally, when we get into driving costs in the marketplace, regulation has been a big cost driver across the healthcare continuum and the healthcare ecosystem. In 2022, hospitals were required to report on more than 80 measures to CMS. And a lot of these measures, while they do indicate quality, don't necessarily tie to outcome. There's a big disconnect between what we're measuring at an aggregate level and how the patient experience happens, and ultimately their outcome and quality of care. These types of drivers can have negative impacts, like steering patients to the wrong providers for specific diagnoses just based on their star rating or their patient experience. They can create more expenses for low value care when outcomes are what really matter, and they fail to adjust for specific patient needs. It doesn't really get down to the diagnoses of individuals outside of diabetes and congestive heart failure at an aggregate today. And while there are quality metrics that matter, like reducing hospital readmissions, the truth is that a lot of these are disconnected from what really matters in the healthcare space, which is, did the individual get healthier faster, and what did it cost us? And because of those reliance on qualitative metrics, things like HEDIS scores and hospital satisfaction scores, patient experience has been drastically deprioritized because we're literally just tracking whether or not we're hitting these 80 metrics, and they're not all tied to patient experience in any way. We also don't get actionable insights. For those of you that work in the Medicare space, we know that a lot of times our star ratings, all the data, while we may have a little bit of a forward look on what it's going to look like with measures, really is a 3-year to 2-year look back. And because of that, we don't get actionable insight into how to improve quality and cost of care. Instead, we're planning on how to improve our star rating, which isn't necessarily tied to health outcomes. And that's because there's a disconnect between the spend and the outcomes in the qualitative metrics today. And to drive meaningful, sustainable improvements, healthcare organizations, we need to embrace a data-driven approach that aligns quality spend with tangible, measurable outcomes. These have major impacts across the United States, right? Specifically for health plans and employers. Aside from GLP-1s driving up health costs, site of care as well as just general inflation and overall increase in costs, make managing medical loss ratios very difficult. We're stuck between a decision of either passing costs on in premium to our members or reducing benefits or network or coverage for prescription drugs in order to maintain MLR compliance and keep our plans in the black. We also don't have any visibility into what the cost drivers are in the marketplace. This fragmented data between your care network creates a major issue for you when you're trying to get a holistic view of trends within the marketplace. And that's because when you don't have that holistic view, you have no ability to link interventions to ROI. So when we think about things that an employer or a health plan can do, a lot of times we're simply testing interventions, hoping that we see an outcome. But because we're looking at quality metrics as kind of a front leader, and then we're looking at what the actual cost was once we've already paid the bill, it's very difficult for us to justify the cost savings initiatives on interventions for specific diagnoses. And then finally, when we talk about health plan employers, I see a couple of you are here from health plans or employers. Productivity and workforce impacts are a major problem, right? If we can't keep our people healthy, they're out of work more often. When we talk about workers' compensation, absenteeism has a major impact on our abilities workforce to be productive. And that strains our HR budgets and also drives up our overall healthcare costs from managing those out of office instances. So, Scott, tell us a little bit about how IntegerHealth solves these problems.
All right, thanks, Justin. Well, we started the company a couple years ago. Our founder is Dr. Jack McCallum, and Jack was a neurosurgeon for 30 years and then began founding healthcare technology companies. IntegerHealth is actually his fifth one. The one right before us, you may have heard of it, was a company called Senseo Health. It's since changed its name to Signify Health, and it ended up selling itself to CVS last year for $8 billion. So Jack has had a lot of success in healthcare and healthcare technology. What makes IntegerHealth so unique is that we quantify healthcare outcomes. And we've got 4 patents and counting on these unique methods. It's like no one else does this. And we quantify healthcare outcomes for health plans, wellness programs, and workers' compensation programs. And we do so across the healthcare spectrum. We work with health insurance companies, workers' comp insurance companies, including ASOs and TPAs, health systems, and self-insured employers. So what do I mean by quantifying a healthcare outcome? Well, you can think of healthcare as an equation. You have your inputs, and then you get your output. The input into that healthcare equation are the dollars that you pay to doctors and hospitals. Then you have to measure your output. And the traditional way of measuring that output in healthcare is through quality metrics, which are, of course, qualitative, not quantitative like the dollars that you put in. So you can't compare one against the other. And these quality metrics focus on the process, what a doctor did or did not do. Did the doctor follow clinically based guidelines or evidence-based medicine? Did the hospital get good HEDIS scores? Or did the patient like their doctor, their healthcare experience measured by Press Ganey and CAHPS? And that's going to have as much to do with how long they sit in the waiting room than anything else. And at best, these quality metrics are just proxies for what really matters anyway. And that's the patient's outcome. Did the patient get better? And if they did, how much did it cost? And how long did it take? And that's what we do at IntegerHealth. We combine cost and quality into a single dollar value that you can now compare back against the dollars you paid to get that outcome and calculate your return and your ROI. And you can evaluate and rank things at the diagnosis level based upon the outcomes they achieved. Who's the best primary care physician or PCP in your network for treating diabetes? Who's the best surgeon for knees? Which hospital is best? Diagnosis by diagnosis. On treatment patterns, are you getting better results sending your back patients to chiropractors or physical therapists? That's what we do at IntegerHealth. We quantify healthcare outcomes, and that's something that no one else does. So how do we go about quantifying a healthcare outcome, combining cost and quality into a single dollar value? Well, we have 2 methods. One is called claims plus absence costs. The other is called claims per healthy day. Which one we use depends upon who we are working with and what data they can send us. And we have patents on both of these methods because they're so unique. No one else out there does this. Let me start with the claims plus absence cost method there on the left of the screen. In claims plus absence costs, we define a good outcome as the employee being at work. And we use this method when we're working with a self-insured employer, looking at either their health plan or their workers' compensation program. And we also use this method when we're working with workers' compensation insurance companies and TPAs. So what we do is, after defining a good outcome being the employee at work, we accumulate all the costs to get and keep the employee at work, all the medical and pharmacy claims, and all the absence costs related to those claims. So in claims plus absence costs, the claims are the cost component, and the absence costs, they straddle both cost and quality. They are real cost, but those absence costs are also an indication of the effectiveness of the care, because the quicker you can get the employee better and back to work, the more effective that care has been. So how do we get the absence costs? Well, we juxtapose the claims dates against the employer's HR attendance records and payroll records. So if we see that the employee had a medical claim for a hospital stay on Tuesday, well, we assume that the PTO day that they took on Tuesday is related to that claim. And then we value that day off using the employer's payroll records. Now, when we're working with a workers' comp insurance company or TPA, we're not going to have the employer's HR records. So instead of using the absence costs from the HR records, we substitute the lost wage indemnity payments paid to the injured employee. Now, when we're working with a health insurance company or a health system looking at their operations or a commercial plan they may sponsor, or even the dependents under an employer's health plan, we're not going to have any absence costs to match up against those claims. So we have to flip the question. And instead of asking how much it costs and how long it took to get an employee better and back to work, we ask how much does it cost in claims per day to keep someone healthy? And that's claims per healthy day. And in claims per healthy day is a fraction. The numerator are the claims over the course of the year for whatever diagnosis we're looking at for the patient, say diabetes, and the denominator are their number of healthy days. Healthy days are simply the 365 days in a year, less the patient's unhealthy days related to that diagnosis. And unhealthy days are days spent in the healthcare system. You're in the hospital, you're visiting the doctor, or you're at home, but you're not able to function normally, all of which our algorithms can derive from the claims. So in claims per healthy day, the claims, the numerator, that's the cost component, and the healthy days, the denominator, that's the quality component. Now you can think of the absence costs under claims plus absence costs and the unhealthy days under claims per healthy day as two sides of the same coin. They're both looking at quality of care. In claims plus absence costs, what we do is we take those days away from work, monetize them using the HR payroll records, and add them to the claims. In claims per healthy day, those unhealthy days we subtract from 365 to get the number of healthy days, which is the denominator in the calculation.
And when we look at how we would incorporate and use this strategy for employers, it's really about integrating absence data, so that way we can link lost conditions to lost work days. From there, we can target interventions and demonstrate a non-medical ROI. What's been missing in the current way that we analyze claims for health plans and for employers is really an ability to link both what their claims costs are from a medical perspective, both in workers' compensation, as well as what the claims cost is from the individual being, or at least the non-medical cost for the individual being out of work. By tying the two together and using those metrics to determine what we consider to be a good outcome for a particular employee or member, we have a strong way to analyze and put everybody on a level playing field as to what value a particular strategy for intervention can provide, or how we can demonstrate non-medical ROI with the implementation and change of a benefits program, benefit design, or network design. And Scott, if you could tell us a little bit about what we're looking at here, just to give an example of what we can do.
Now, this is one of the most interesting things we ever found in a data set. And it comes from a very large employer in the Northeast. And here we're looking at our claims plus absence cost platform. This particular employer had a network of orthopedic surgeons, and within that network were the two highest volume orthopedic surgeons, Surgeon A and Surgeon B. And both Surgeon A and Surgeon B did neck surgeries and back surgeries. So using the claims plus absence costs method, we decided to look at their neck surgeries first, and that's the chart there in the upper left. So we compared Surgeon A and Surgeon B against one another, and then the group average, that 50th percentile. Now, before I go any further, you'll notice that the title of that chart says neck surgeries risk adjusted. Something we always do in our outcome analytics is we always risk adjust the data, and we always allocate to a doctor or anything else we're looking at all the costs and unhealthy days that they're responsible for. First, risk adjustment. We always risk adjust because if you ask any doctor why they cost more than another doctor, They will always give you the same answer because my patients are sicker. And sometimes they're right. So we have to adjust for that by assigning each patient a risk score to kind of level the playing field when we're comparing doctors. Give you an example. Say you've got two patients, identical back injuries. First patient, they're 20 years old, otherwise healthy, run marathons on the weekends. Second patient, same identical back injury, but they're 60 years old, obese and diabetic. We know it's going to take longer and cost more to get that senior citizen better. So we have to adjust the data and filter that out of the data. So we're evaluating the doctors purely based upon their performances, not whether they got lucky and treated the 20-year-old or unlucky and treated the senior citizen. A lot goes into a risk score, the patient's age, their sex, and a big part are their comorbidities, which are other conditions that they have, like diabetes and obesity, which makes treating them more complicated. Second thing we always do is we always allocate to a doctor all the costs that doctor is responsible for. Not only their direct costs and unhealthy days of treating the patient themselves, but also their indirect downstream costs and unhealthy days when they refer the patient on to specialists and surgeons. Go back to our example of the two patients with the identical back injury. First patient goes to their primary care physician or PCP. PCP sees them for 15 minutes, refers them on to a surgeon. Second patient goes to their PCP, identical back injury, but this doctor doesn't refer them on to a surgeon. Instead, the doctor has them come back multiple times to rehabilitate them without the cost of the surgery. If we just look at each doctor's direct costs, that first doctor is going to look much better. They just saw the patient one time for 15 minutes versus the other doctor who saw the patient multiple times. But if we look at everything that doctor is responsible for, the direct costs and the indirect downstream costs, now that second PCP is probably going to look much better. Even though they saw the doctor multiple times, they're not going to have that expensive surgery allocated back to them. And this is very important because it allows us to evaluate a doctor's referral patterns and make adjustments when appropriate. A lot of times they'll see a doctor that when they're treating the patients themselves, they're doing just fine, but they're referring to the wrong specialist or the wrong surgeon. That's a problem that's easy to correct. Now back to our tale of the two surgeons, Surgeons A and Surgeon B. In the upper left, we looked at their neck surgeries. Surgeon A was much better than average. Surgeon B was much worse. So we thought, well, we'll go a few vertebrae down the spine, look at their back surgeries, and we'd find a similar result. That's the chart on the right. We were completely wrong. It was totally reversed. Now Surgeon A was worse than average and Surgeon B was better. And that's something we often find in the data. It's not that a doctor's all good or all bad. They're good at some things, not so good at other things. And what these analytics do is they find out what they're good at and exploit it to everyone's advantage. This particular employer had taken the patients going to these two high volume orthopedic surgeons and flipped them around so that each surgeon only did what they were good at. Surgeon A did all the necks, Surgeon B did all the backs. The employer would have saved $1.2 million over 4 years. And the surgeons wouldn't have cared. They'd still be doing the same number of surgeries. Now they'd just be doing the surgeries that they were good at. Now, these outcome analytics are very powerful. And a way to calculate just the magnitude of the power that we're dealing with is we like to calculate savings opportunities. And one way to do that is to say, if you took all the patients going to a worse than average doctor, if you moved them just to the average, the 50th percentile, how much could you save? So here we're looking at 14 specialists taking care of back patients. The green line there is the group average. That's the 50th percentile. $6,206 to treat, on average, to treat a back patient. So specialists 1 through 7, they're better than average. Their costs are lower than $6,206. And specialists 8 through 14, they're worse than average. Their costs are above $6,206 on average. Now, there were 146 employees in this data set, and 63 of them went to these worse than average doctors. So if we just took those 63 patients and moved them down to the average, not to one of the better doctors on the far left, but just to that green line, we would have decreased their claims cost 29% and decreased their absence cost 40%. Now, are you going to get everyone going to a worse than average doctor to move? No. But you don't have to, because when you do this analysis across your entire plan or program for all the different diagnoses, the numbers just become enormous. If you just get a fraction of that number, you're going to reap a windfall. And those folks that do move from worse than average doctors, they're not going to move to just an average doctor, but to one of the better doctors on the far left.
And when we talk about how we do this for health plans in comparison to how we would do it for an employer, the process is similar, but we use a different patented metric. We start by leveraging claims data analytics. We're going to identify all the high cost claimants, detect at-risk populations, and pinpoint the specific conditions driving up medical cost ratios, both impacting your employees as a health plan as well as your members. From there, we're going to introduce the claims per healthy day metric. We're going to take all of that data and look at how much did we spend and how many days did they stay out of the health system, and combine that to a single dollar and cent value so that you can assess your different plans that are available in the market and the treatment plans within them. Then we'll optimize the network and benefit design. This is something that health plans and employers both can leverage in the marketplace, right? When we talk about negotiating new provider networks or contracts, there's a big drive towards value-based care. By being able to optimize both your network and benefit design around the things that are driving your high MLRs, things like GLP-1 treatment and all of the treatment that goes with it, things like site of care, where sending it to one outpatient hospital facility triples or even 10 times the cost compared to another. We can trim that network or stratify that network and create a new benefit design that it encourages members to visit the sites that both produce the highest quality at the lowest cost. And that allows you to align those incentives within both your provider directory as well as within the health plan at large, for those of you that are in value-based care risk-based contracts, further moving you towards a lower MLR and better health outcomes. It's really a magic way, from my perspective, on how we can level the playing field when you're looking at the data analytics and assess every facility and every doctor on an even playing field to make decisions.
So here we're looking at our claims per healthy day platform. And remember, claims per healthy day is a fraction. The numerator are the claims over the course of the year for the particular diagnosis we're looking at. The denominator are the patient's healthy days. So we're looking at 10 primary care physicians taking care of 4 different chronic conditions. And you can see that there's quite a variance between the 4 chronic conditions and then the doctors actually treating them. The orange line there in each chart, that's the group average. If the doctor's column is below that orange line, they're better than average. If it's above the orange line, they're worse than average. So the averages for the 4 different chronic conditions, they're very different for each particular chronic condition. And then if you just look at one chronic condition, there's a wide disparity between the outcomes that the doctors treating that particular chronic condition are achieving for their patients. As I mentioned before, all these calculations have been risk adjusted. And when allocating costs on unhealthy days, what we've done is we've allocated to all these doctors all their direct costs on unhealthy days and all their indirect downstream costs on unhealthy days when they refer their patients on to specialists and surgeons. Some of these doctors, you notice, have green in their bars. That's the quality of life adjustment. And what the quality of life adjustment does is it further separates those doctors taking good care of their patients from those that aren't. When a doctor's average unhealthy days are above the group average, we take the value of those excess unhealthy days, monetize them, and then add them back to the doctor's claims in the claims per healthy day calculation. Now we're going to look at how to calculate the savings opportunity using the claims per healthy day algorithm, much like we did before with the claims plus absence costs. But instead of looking at back specialists, now we're going to look at cardiac surgeons. So in this data set, we had 19 cardiac surgeons, and the average claims per healthy day, the 50th percentile, was $5.68, the cost to keep one of these heart patients healthy during the course of a year. So specialist numbers 1 through 8, they're better than average. Their average claims per healthy day is lower than $5.68. And specialists 9 through 19, they're worse than average. Their average costs are higher than $5.68. There are 672 patients in this total data set, and 416 of them went to these 11 worse than average surgeons. All we did was take those 416 folks and move them down to the average, not to one of the better doctors on the far left, but just to that average. We would have decreased their claims costs 35% and decreased their unhealthy days 21%. Now let's switch gears a little bit and talk about wellness programs. Every employer has wellness programs, from your general wellness programs that are open to everybody, like a walking program where you count your steps, or a wellness program that's specific for a chronic condition, like a diabetes management program. Vendors will always shovel back to the employers all kinds of qualitative metrics to show that these programs are working. Example for us, a walking program, how many steps the employees are taking. In a diabetes program, they'll tell them what the A1C scores are. But the problem is these are quality metrics, and particularly in baseball, we don't let the pitcher call balls and strikes. So what we did was we took our outcome analytics and we built a patented wellness program ROI calculator that calculates the actual return on these programs and then their real ROI, which is often a lot less than the vendor has promised. Now, I'm going to show you how we do that. But if after today you're interested in a deeper dive, we wrote an article entitled How to Calculate the ROI on Your Wellness Program that was published in World at Work's peer-reviewed Journal of Total Rewards. Now, you can think of our platforms, whether it's the claims plus absence cost platform, the claims per healthy day platform, or this wellness program ROI calculator as engines. The gear's right there in the middle of the slide. And what every engine needs is fuel. And in this particular case, what the fuel is going to be for the wellness program ROI calculator is it's going to be the inputs there on the left. The medical and pharmacy claims under the health plan, the HR attendance records and payroll records, and then the wellness program enrollment and cost. And the engine is going to grind through that data, and the algorithms are going to produce the output on the right. And that's for the program we're looking at, for the employees participating in that program. How much did their medical and pharmacy claims go down? How much did their absence costs related to those claims go down? And that's going to be your return on the program. And we can do that on an overall basis for all the claims and related absence costs, or for just specific things like a diabetes claims if we're looking at a diabetes management program. So those decreases in claims and absence costs are going to be your return on the program. We already know what you spent on the program. And from there, the wellness program ROI calculator, which we got a patent on as well, calculates the ROI. Now, once we do that, many of you are going to ask, why is my ROI so low? And it's because employees self-select. You can think of your employees as in two buckets. First bucket are your employees that are very conscientious about their health care. Second bucket, those employees that aren't so conscientious about their health care. You adopt a new wellness program, which bucket you think is going to sign up? Well, it's going to be that first bucket, the folks that are very conscientious about their health care, because now you're giving them another way to be healthy, and they'll be the first ones to sign up. The problem is these folks don't have much room to improve. They're already very conscious about their health care. The folks that have a lot of room to improve, where a wellness program could really help them, is your second bucket. Because they're not very conscientious, they don't bother to sign up. Which leads us to the byproducts that this engine will throw off down there in the blue circles below the gears. One will be a list of employees not participating in the program who should be. The other will be a list of programs that the employer should consider adopting that they don't have. As for the list of employees that should be in the program that aren't, you can have the case managers under your health plan call them up and encourage them to participate in the program. And if you can get them into the program, then you might be able to start to approach those ROIs that your vendors promised you.
And from a proof point perspective, if you want to see the results of our analytics in what we've done over the last 3 to 5 years, we have multiple case studies and examples. I'm also going to trigger a handout that if you look on the right-hand side, each one of these will be available for download for you directly from the webinar. Now, Scott, I want to kind of dive into one in particular, which is the Fort Worth case study. Could you tell us a little bit about that study?
Sure. The Fort Worth case study, it was a nationally published case study that documents how our outcome analytics, specifically the claims plus absence costs platform, drove down the city of Fort Worth's workers' comp costs 23%. Now, in 34 states, including Texas, you can direct care in workers' compensation. You can tell that injured employee what doctor they have to go to. So what the city did was they sent us their data. We went through their data, and using our outcome analytics, we identified the best doctors for each type of injury. And the city then put these best doctors into a proprietary network that their injured employees had to go to. End result, they drove down their costs 23%. Now, when the city sent us their data, they sent us both their health plan data and their workers' comp data, which gave us a couple of advantages. First of all, a shortcoming in a lot of workers' compensation data sets is that they don't contain comorbidity data. Remember, when we're comparing doctors against one another, it's very important to do so on a level playing field. So we assign each patient a risk score to kind of filter out things. Now, a big part of it is going to be that risk scoring system is going to be the patient's comorbidities. Are they diabetic? Are they obese? Because if you break your leg and you're diabetic and obese, you're going to cost more and take longer to get better than if you break your leg and you don't have those comorbidities. Now, because we had the City of Fort Worth's health plan data, we could go into their health plan, get those comorbidities for the employees, and use that in applying that to the workers' compensation data set. Second advantage we had was because we could now spot doctors doing a great job for the city under their health plan that weren't currently doing any work for them on their workers' comp program. And the city could invite those other new doctors to join this new proprietary workers' comp network that they were setting up.
Wow, it's really cool to see, like, comparing for, especially when we talk about employers, both health plan data and absence cost data. I feel like that's why I really like this study, because it's a very unique application of how we can use analytics to take a holistic view of a health plan's workers or a employer's workers compensation plan, and then tie it to health plan data to drive better outcomes and make better decisions. And we've done that across multiple markets and with multiple different employers and health plans across the United States. We've helped individuals improve knee outcomes in Ohio. We've helped drive health plan costs down and provide better care for health plans. And then we've also just defined what health plan savings really mean in the marketplace with our patented analytics. If you look on the right-hand side of your screen, these are all available for download if you'd like to download any of these studies. And as we get into how the system actually looks, when you interact, like, we have a wonderful portal that lives online. It's super easy to use. What you're looking in the middle is actually called the tree frog navigation. This is also patented. We call it tree frog because it looks like the bottom fingers of a tree frog, right? And what it starts with is when you log in and we've uploaded all of your data, you're going to visit our online portal that's either self-hosted, meaning we can do it on premise, or that we host for you. From the beginning of the screen, you get insights in the middle. These are those savings opportunities that we talked about, and any other analytics insights that we've defined as part of the relationship that you're looking to drive down MLRs with. From there, we also design individual portals for each individual entity or group that is involved in driving down those MLRs. That means case managers will have a portal to identify the best providers for patients with high costs and chronic conditions. Your physicians within your provider directory and your network will be able to look up the best specialists for referrals for surgeons. And then finally, your patients can be fully integrated into a provider directory that's now prioritizing and displaying doctors based on their actual value of health outcomes and whether or not they got people better faster at a cheaper rate. It really is powerful when you use the full platform to make an impact. These individual portals are invaluable tools when we talk about actually putting the analytics to work and creating actionable insights for your organization to make an impact on your MLRs and your overall plan design. Now, Scott, could you tell us a little bit what we're looking at here?
Sure. Well, all of our analytics are proprietary to us. The Claims Plus Absence Cost platform, the Claims Per Healthy Day platform, the Wellness Program ROI calculator. We have patents on all of them, and we built them from the ground up. All the algorithms, all the groupers. The only thing that isn't proprietary to these platforms is the risk scoring system. And we plug and play with any of the number of risk scoring systems that are out there. And it makes it easy for us to customize these platforms if a particular employer needs to have a certain dashboard or a certain report. But after we did this, we decided, well, what if we took our unique way of looking at things and applied it just to traditional claims analysis? And the result is our guided analytics. And it's going to give you visibility into your claims that you never had before. What guided analytics do is they stitch all the claims together to tell a story instead of looking at one claim at a time, telling you not only what happened, but why. And I'm going to tell you one of those stories right here through a couple of dashboards from our client portal. This particular dashboard is a summary dashboard, and it's looking at an overall at one employer's health plan. Upper left corner, we're comparing the total claims under this employer's health plan year to year. You have a green down arrow with 3%, indicating that overall claims under the health plan for this employer went down 3% year to year. Below that, in the lower left corner, this particular employer had 3 different options for its employees to choose from: PPO, HSA, and HRA. And what this graph is doing is it's charting the claims under each of those options quarter to quarter. Then over here on the right side of the dashboard, we've got the 15 top diagnoses groups for the employees and the dependents, with bars for each diagnosis group comparing 1 year to the next. If you got a red box next to the bars, it means the claims went up year to year. A green bar means a green box means they went down year to year. Now, guided analytics is designed to allow you to drill down constantly to find with easy clicks the answer you're looking for. So for example, we see that under the employee column, diabetes claims for the employees went up $788,000 year to year. So if we want to find out, well, what's going on with these claims? Why did these particular claims go up? We can go in and click on those diabetes bars and it'll bring up this dashboard. Now this dashboard shows on the left there are all the different filters that you can filter the data by. And we can slice and dice the data by any metric that's present in the data set. It would have been pre-selected to diabetes because that's what we clicked on. To make it a little bit more interesting, I added COPD and COVID, and then I expanded out the data set to include the dependents too. Middle of the dashboard, well, that's just various metrics and charts to show you what's going on. And then over on the right, again, we've got the total claims year to year for the 3 diagnoses I selected. Again, we want to find out what's going on with diabetes. We click on those diabetes bars and this dashboard shows up. And this dashboard shows us all the things that this employer was spending money on to treat diabetes under their health plan. Again, over on the left side, we've got all the filters we can slice and dice by. The middle has various charts and metrics. And then over on the right are the bar charts. This time they're showing all the different cost categories of claims where this employee was spending money to treat diabetes under their plan. And because it's diabetes, well, pharmaceutical drugs are by far the biggest category. So if we click on those RX bars, this is the dashboard that'll show up. And it gets really into the details. If we go down here into the lower right-hand corner where it says treatment details, the row I've highlighted, we find out what one of our big culprits were that were driving this increase in diabetes costs for the employees. It was under the HRA plan for the employees, a drug called Victoza. And the prescription price for that drug went up from 1 year to the next 41%. From $1,346 per prescription to $1,902 per prescription. And that's what guided analytics do. It allows you to drill down and figure out not only what's happening, but why it's happening. Now, outcome analytics are very powerful. They're also actionable. When you can quantify a healthcare outcome, you can do all kinds of things that you couldn't do before to both drive down your healthcare costs while improving the quality of care. And this slide just shows some of them, and I'll walk you through it. Upper right-hand corner of the slide. Now you can evaluate and rank things based upon their outcomes. Who's the best primary care doctor in the network for treating diabetes? The best surgeon for knees? The best hospital system or hospital, diagnosis by diagnosis? Treatment patterns. Are you getting better outcomes sending back patients to chiropractors or physical therapists? You all have case managers taking care of your chronically ill folks and your high-cost claimant. Which case manager is doing the best based upon the outcomes they're getting for those folks, both overall and for diagnosis by diagnosis? Same thing in your workers' compensation program. Which adjuster is getting the best outcomes? Now, I realize that every insurance company and plenty of other companies rank doctors, and they'll tell you who the best ones are. What you have to ask yourself is, what are they looking at to do so? In every case, what they're looking at is those quality metrics I talked about in the beginning that focus on the process, what a doctor did or didn't do, HEDIS scores, did the patient like the doctor? These things are just proxies at best for the only thing that matters, and that's the patient's outcome. Did they get better, and how much? If they did, how much did it cost, and how long did it take? At IntegerHealth, we do not look at proxies. We quantify that actual outcome. Going over to the upper left, now you can do things to optimize your plan and your network design. For example, if you're an employer, you probably have multiple options under your health plan for your employees. One might be a PPO, the other might be a high deductible plan. You want to compare those two plans and how they're doing. If you just look at the claims, well, you might think the high deductible plan is doing just great, but the outcomes might tell you a different story. Because under the high deductible health plan, those employees are going to be paying a greater share of their healthcare expenses. If they're having to pay a greater share, some of them might be deferring care. And if they're deferring care, they're going to be getting sicker and missing more work. So what the employer saves in lower claims costs, they're going to more than lose in employee absenteeism and lost productivity. Now, if you're a health insurance company or a health system, now you can actually evaluate your provider networks based upon their outcomes and put the best ones based upon their outcomes, diagnosis by diagnosis, in a narrow network. And you can identify the poorer performers, particularly lower 10%, and do things to counsel them to get better or eliminate them from the network. If you're an employer, you're not going to be able to go to your insurance company and ask them to change their provider network for you. But there's still a lot you can do to get those folks to the better doctors in the network that you have. You can stratify the network. You can tell folks, you can go to anybody in this network you want, but if you go to these better doctors based upon their outcomes that I know are going to cost less overall and get you better care, I will eliminate or I'll decrease your copays and your deductibles. If you have a high deductible plan with health savings accounts, you can even pay folks to go to those better doctors by contributing to their HSA when they do so. Going down to the bottom left corner, now you can direct and steer care. And here there's a fundamental difference between health plans and workers' compensation. In the health plan scenario, I can tell you who the best doctor is for you to go to. You can still go to wherever you want to. Not so in workers' compensation. In 34 states, you can direct care in some form or fashion. You can tell that injured employee what doctor they have to go to. That's what we did for the city of Fort Worth, and it drove down their workers' comp costs 23%. There's still a lot you can do in the health plan setting, though, to get folks to the better doctors. You can work through the case managers. You can give them a portal where they can look up the best doctors based upon outcomes, diagnosis by diagnosis. Those case managers, they're going to be working with your high-cost claimants and your chronically ill folks. And that's where most of your dollars are going to be anyway. Now, those case managers, they can't direct care. They can't make those folks they're working with go to the better doctors. But those folks are looking to the case managers for guidance. So they can certainly steer them in that direction. Do the similar thing with the physicians in the network. Tell them, give them a portal of the best doctors that they can use when making referrals to specialists and surgeons. And this is going to be particularly powerful for employers that have employee clinics that are the first stop for their employees to go to. Now the PCP staffing those clinics will know who the best specialists and surgeons are when they're making the referrals. You can do the same thing with the patients. Give them a portal telling them who the best doctors are, diagnosis by diagnosis. And you can integrate that patient portal with your insurance company's Find a Provider tool, or give it to the concierge service that the employees are calling to get recommendations. Moving over to the middle, we talked about our patented wellness program ROI calculator. Every employer has wellness programs. They really don't know what they're getting in return for their money. Now they will. They'll know the real ROI. They'll know if those programs are working. And if they're not working, they'll know what to do about it. And then finally, in the bottom right corner, talked about our guided analytics, applying our unique way of looking at things to traditional claims analysis. Guided analytics stitch all the claims together to tell a story instead of looking at one claim at a time, telling you not only what happened, but why it happened.
And at a high level, we're really looking to make an impact in MLRs, right? When we think about the rising healthcare costs related to inflation, when we think about GLP-1 costs driving up, when we think about site of care having a major impact on the cost within your own networks and the quality metrics that we all have to report on, we're looking to improve that across the board. And that's exactly what our guided analytics do. I'd love to get in touch with each and every one of you, but before we get there, I want to open up for questions. If you have any questions, please go ahead and type them in the chat on the right-hand side. And then Scott or I will answer it depending on what it is. So go ahead and take a little time to answer any questions. I'm happy to field any that you guys have. Here's a good one. What's the process for actually reviewing claims for health plans when we look at this from a data perspective? I can take that. We'd usually take 3 to 5 years of your data from a look back. And then when we have that data, we put it against our analytics machine. What we need that 3 to 5 years of data to start. So that's usually the biggest challenge for a lot of health plans is just getting that data together. And when we meet, we'll actually go over what the data requirements would be in order to do that. Once we have that data, we're going to apply that claims per healthy day metric. In a lot of cases, we take a pilot data for a lot of our new customers, meaning that we'll take a subset of that data for a particular thing you're trying to improve, GLP-1 costs, site of care, particular diagnoses, and then produce that data so that you can see what kind of benefit you're going to get. We also have a demo for health insurers that when you join with us or book an appointment, I'll walk you through exactly what you would see from a health insurer's perspective once all the data is uploaded. From a process perspective, though, we try to make it as painless as possible. Whether you want to do hosted or on-site, it's up to you and your IT team on how you want to deploy that. All right, well, if you have any other questions, I'll leave it open for a minute or two and I'll keep an eye on the chat. But in the meantime, if you're interested in booking an appointment, go ahead and book a call with us. You can either schedule a consultation just by emailing me at justinbieber@integer.health.com, or you can click this wonderful little button in the corner that just popped up that says book a consultation. And that'll actually give you direct access to my calendar. You can schedule time that's available for you. And then we'll go through the step-by-step process. We'll strategize on your use case, identify areas of focus that we think we can target with MLRs and our guided analytics to really tell the whole picture. We'll review the data requirements, and then I'll also demo and show you the solution in action. So feel free to book a consultation or give me an email. I'm available Monday through Friday, on weekends if we have to be. And otherwise, I want to thank you all for joining us today on this wonderful webinar about confronting healthcare cost pressures, a patented framework for health plans and employers. Feel free to reach out afterwards if you have any additional questions, or you'd love to just see some of these studies as well for whatever reason. You want to look at the wellness ROI calculator, or just have a conversation about what's going on in the marketplace. We'd love to drive the conversation forward, find new ways that we can help, and really just contribute to the overall thought leadership of the industry on what we can do to drive MLRs and healthcare costs down in the new 2025 environment. So thank you all for attending again, and have a great rest of your Thursday.